Hello. Yeah, I think we should start the next session. Uh, so yesterday we had a all technical discussions in the morning, but today morning is scheduled to be all clinical discussions, and we have heard from many clinicians on their experience of using AI solutions and how they work uh, in real world scenarios. This will be followed by a discussion on democratizing AI, and the discussion will focus on regarding cost, scalability, and implementation of these solutions. To coordinate this session, I'll invite Professor Khurana and Dr. Ram. Uh, since we are running late, may I request you to close this session by 1 p.m. Thank you. Over to you.
Thank you. So welcome back after the coffee break. We now move on to a very interesting session, and it's called Democratizing AI. I don't believe that democracy is the best way to be, but nevertheless, it's a nice word to use for a session. We do believe in dictatorships from time to time. They help. But the discussions are interesting. The discussions are going to be on cost, on scalability and awareness among physicians, which really means we have to learn how to make the best of life and get the best out of it, even though, as we know, life sucks. Nevertheless, we have put together, and I must congratulate Ram for doing this and Condi for being very supportive, that we're going to have 4 people speak on this initially. And then beyond that, there will be questions that we have framed for everybody, which is supposed to frame our speakers, but nevertheless, we also will give the audience a chance. And our first speaker today is Mr. Mahendra Mehra. He's from what we refer to as industry, which means that he sells ultrasound machines, which also means that he helps develop them. He helps convince us that this is what is good for our patients. And he is a friend. In Delhi, we often competed for young girls who wanted help with ultrasound, but he was always the winner. Mahendra, we want you here on stage. And if you could please come to the podium. He's currently with Sonoscape. There used to be a time when we never used to take names. We used to think it was unethical. We now realize that it is necessary to take names. We used to give things, actually at the beginning of every talk, something called disclosures. And we used to pretend that we don't work together and that disclosures is a bad word. It's not a bad word. If you don't work with industry, they will turn out rubbish. You will be forced to use that rubbish, and therefore you have to impose yourself upon them. Does not mean that you have egg and toast with them, but the fact is that we have to work together. And he has produced some fabulous machines. And I'm looking forward to him giving us this presentation for letting us know what they have and how they've brought in cost factors, how they can upscale and downscale and educate all of us. Yes. I think we have to press the mic again. It's got unpressed.
Yeah, so as I was saying, sir was always the winner. So can we start with the presentation, please? Okay, as I was saying, I think I thank Dr. Khurana and Dr. Ramachandran and the organizers of this conference to providing me this opportunity. I think this is a great setup, and I think Dr. Khurana really knows what's happening in the industry, especially the ultrasound globally. That's why he's able to get together the speakers, especially for this kind of session, because it's very important for all present here to know what exactly is already available, because probably we might say that some companies working on this AI on fetus or that application. But the case might be that that application is already available in the industry for a couple of years. So I think in my presentation, I'm very sure I'll be able to show you what already, my company name is Sonoscape. We are a global company in 130 countries, and I can say with pride, we are really leading in AI technology. I think by the end of my presentation, you will also agree to that. And Dr. Khurana has been a very close supporter, and in future also, see, sometime in YouTube, you say, please stick to the presentation till the last. So the last slide, which I'm going to show you, is like a dream come true. It's really, at least at my level, unimaginable what my company has come up with recently. So this is the way I move the slide. So I think ultrasound is a modality, because I worked with different modalities in my career, but most of that has been in ultrasound. See, couple of things which I can say. Ultrasound is very dynamic. Ultrasound is the modality which needs a doctor. It needs a doctor, or probably most of the time X-ray, CT, MR can be done by a technician. But ultrasound is a live scan, and baby always moving, as Dr. Khurana mentioned, and every one of us know. So ultrasound, getting an AI at that level in ultrasound is the most challenging thing, which I think great work has been done by the industry. So I'll not go through all this. I think most of the speakers have covered this, but I want to show what our company has been able to offer. I'll not cover all these AI applications which are available in our machines in today's session, but I'll cover mainly the ops gynae and just show you some glimpse. See, the thing is, I think we say AI in healthcare. It might help, it might improve a bit in developed countries, but India is the country where the AI is most needed. I think we already touched that in rural towns and villages. I think this kind of technology, which I'm going to show you today, we might have, it's like having 1,000 Dr. Khuranas in every village, because this has been developed by our top KOLs across the world, like Dr. Khurana. So their experience, expertise, we've been incorporated into the our machines. See, it's a totally one touch. It's a one touch. Ultrasound has been so, usually conventional is so cumbersome. Doctor scans for only 10% of his time, but 80-90% he's fiddling with the machines, which they really don't like. All that has been covered by the technology right now. Then the main point, as you know, it covers all. It is like a assistant to an expert doctor, and this same technology is like a tutor to a less experienced ultrasound doctor. So it covers a wide range of clinicians. So obviously so as you know, we have millions of data, then all this work has been already done at the back end by the company. But today's session, I want to concentrate more on what is the practical benefit which our clinicians have experienced. And if I talk of mainly the applications, which I'll cover one by one in this, which probably Dr. Khurana also has experience for a short while, is S-fetus. S is the word which we use, you can say, for our AI as a brand. And this is what it results. Till now, this is what has been going on. This technology we have for a couple of years right now. And we have several top users across the globe using this technology very efficiently. So the main point is, till now, what we are seeing is the doctor has to be in that area and he doesn't have to freeze. See, the main point, again, I repeat, in the Sonoscape products is we don't have to freeze. Machine automatically detects where that frame you need to stop. Like all the fetal measurements of BPD, SCAC, everything will be detected by the machine automatically. And this is one part comes on, and not only for fetus, we have covered all different areas related to, you can say, maternal health. It might be an endometrium, so detection of that exact area where it need to stop, automatically give all the measurements. It can be on follicles. It's freely available on pelvic floor, all the assessments and the measurements, everything done by the machine automatically, even in 2D or in our 3D applications, just by a touch of a button. and the spine, which Dr. Khurana just touched in his previous session. You don't require any ROI or any line. Machine automatically removes all the placenta, gets the right line automatically behind the scene, and gives you the best view in a 3D, 4D. Same way for the face. Many times, doctors have to struggle. Placenta is coming on the face. They have to keep on moving their line. Most of the session, they are trying to get the line properly within that fluid area. But here, just a one touch, you're going to get the best result in 2D also and in 3D application. Just I'll touch furthermore application related to thyroid. I'm not covering directly to the subject today, but just to show you if there's a lesion which sometime might be missed by a less experienced doctor, but machine is already always going to get the margins automatically and give all the readings, and sometimes it involves this TIRADS as per the international terms also. And this is available for breast also and also in the thyroids. And look at this. Automatically, it's for shoulders, for MSK. It's available for 6 different joints. MSK is a very developing and very interesting field, but here the machine, it requires a lot of training for our doctors to do MSK scans. But here machine is all automatically able to identify, it's colorizing different muscles, tendons, bone automatically, and is able to nomenclate all automatically. See, have a look. It is able to colorize just by a touch and give the names automatically. So it's available for MSK, thyroid. Now coming to the interesting part which I was saying, yes, we agree the birth defects and the anomalies are the focus area for us. This is the real benefit to our patients. And we know the seriousness of the issue globally. And these are the different kind of birth defects which doctors most of the time come across. So what can industry offer for this kind of situation? Obviously, the ongoing was, again, I'm saying that till now it was, you need to be somewhere in that area. But what I'm going to, and then this is a ISWAG, which we mentioned earlier. This is a standard which most of the views, 8, 16, 20 views, which are followed by internationally by most of the doctors to be taken, especially in the second trimester. So taking this as a reference, working along with the ISWAG, we have come up with latest. This is the latest development which we have done is S-Fetus 4.0. Just have a look where it automatically recognizes section, acquires, saves, measures, judges, everything automatically. I just show you view and it covers everything. All this thing is covered. Just a less experienced doctor has to just move the probe. I'll just come to that view, then I'll come back. Just have a look. He has to just scan and see on the left-hand side, in the background, machine keeps on storing those views automatically. If he goes to all those views which I mentioned earlier with the ISWAG, if you see, and if he gets a better view, it will overwrite. Then he goes to orbit, automatically machine will judge, yes, he's in the right plane, orbit will be stored. He has to just move the probe on the belly of the pregnant lady and it will keep on storing the right. And you can see on the right side, there's a tick mark happening. What all views he has taken, all those will be tick mark without freezing. Again, repeating, without freezing. If you have little experience and this kind of product available in your hand and the accuracy, and then there's a barcode which tells you the image which you have taken, what accuracy you have done this, and you can always go back. All the measurement, everything comes automatically. So this is a real innovation, and it's been a work done for several years now in the background. So it's really practical, and it covers all these views and covers all these applications without freezing. So in just a simple language, little less experience, even in a village or a remote area, he has this much knowledge that this is the area which I have to be there, and with less experience, all these ISWAG-based views and measurements will come automatically. And there's a lot of papers which we have around this. So that's all from my side. Thank you very much. We'll take questions later.
Thank you very much, Mahendra. We will be taking questions. So
sorry, just a short video is there. Just
oh, you're going to play video.
Yeah.
All right.
Yeah.
Thank you very much. And you can't run away as yet because we have questions. So join us here. And our next speaker is Mr. Naresh Kaul. He is from GE and has machines that have, again, like Mahendra Mehra's machines, AI incorporated into them. And I now look forward to his presentation. He's been with this company since ever. And I'm so glad he's moved along with me to make sure that, yes, we moved on from A mode to B mode and so on, and moved on from static to grayscale. And now we've reached where we have. So I'm looking forward to his presentation.
Thanks, Dr. Ashok Khurana, sir, for introducing me to the friends over here. And I think already many of... Yeah, thank you. Thanks, Ashok Khurana, sir, for introducing me to the friends over here. I think already I really seen the technology grow from last so many decades. And we have clearly seen that technology has come to many miles. It's not only GE, but definitely lots of the young, energetic scientists who are all sitting over here. I was just watching their presentations yesterday and really gives me a motivation that yes, we are going to go miles from here. It's not the end. And many a times we see that, okay, we are very, very infant stage in AI, but looking towards the confidence of all the energetic youth who presented the posters, who presented the presentations and are being awarded as well. They're really doing phenomenal job. I think kudos to all of you. And thanks to Ram and Dr. Ashok Khurana to introducing me to this group. Without further delay, I just want to talk about some of the innovations what GE has brought the last 4 decades. Today, definitely we are talking about AI in ultrasound, but main thing is very, very important that we need to have a very good system, robust system in which this AI tool will really work successfully, right? For that, we really need a good kind of a data which can be really worked upon, and you will get the best results out of that. Yesterday, we were listening to a few of the speakers and they really want to take a battle where they would really see the good outcome coming out of those projects. And that's what I am just trying to put in my presentations. And I will try to take all those 3 important points what we have been discussing in this panel discussion. So today, main important thing is that we have to really get the best out of this particular scanning, what we are doing in getting the exams outputs. Then we really need to see what are we lagging today. Okay, it's not that just making one feature, automation feature, but first what is important and relevant for a person who is really doing that particular job. Like for example, let us take an example here. There's a customer who's doing ultrasound. What are the pain points? Right? What are the challenges they are facing today? It's not just going and making an AI. We have to really go into the depth, do some analysis before we go into a project, right? Today, there will be many other fields where definitely lots of people are working, right? But we really need to get synced in, right? We also heard that there are lots of AI tools which are already there in the market, but lots of people may be working it again. So I don't think we should again do the double work on that, but it's very, very important to understand what are the problems we are facing today and the clinical needs. That's what we are talking, and how it is being translating to the feature. So as we see clearly, we saw many other people presenting over here is the relevant data what we need to collect, prepare that in a proper format, have the AI based module training and testing. Now how that data is really accurate for that kind of a project. Not only that, how we will impose and how we'll put it into a workflow. And the workflow plays a very, very critical role. Today, if you're generating an AI tool, it should not be a complex tool for an end user to get already confused into that. It should be very slowly flowing into the workflow when he is or she is doing an ultrasound scan. The workflow is very, very important. And that's how a person who is really needing some solution for his care areas are really taken care of. What we talk in our industry is the feature. What you may say is a kind of project which later on gets a solution kind of a thing. What G is all about is definitely our mission is to take ultrasound accessible to all the places across, make it much more simpler when it comes to a complex patient assessment, faster clinical outcomes, and the decisions needs to be faster. I was also listening to some of the speakers where they said diagnosing. See, today AI is at a level where they will help you to reduce the efforts you are going to put to the last frame, right? AI is really not to that level where they will tell you yes or no, right? It's still in a kind of a frame where it is still dark. It's not what we can say white and black, but still we are working on that. We are jointly working on that, and definitely the time will come where this AI tool will help the clinicians to diagnose also. But today it's helping us to go through that scanning time, to reduce the time which we are spending on taking measurements and calculations. That is what we are talking about here. And always G has been partnering with many of the companies. It's not G is doing everything of alone. They're partnering with many of the names like Amazon, Intel, and Nevada. Not only with the other companies, but definitely we do have tie-ups with many of the clinical experts. Best of the example is right now here. We are definitely having lots of work done on the AI with Dr. Iris sitting over here, and definitely lots of things what we work with Dr. Ashok Khurana sir and many other such elite experts. So that's how the AI comes. It's not only the company who's introducing. So I will just take you to the different aspects as per the application. So let me talk about some of the features in OBGYN. So as I said, like G is not really introducing technology today or innovating today. It has been lots of years, almost 4 decades, that we have been bringing the first in the industry. G has been leading always with the innovation tools, which are really the clinical relevant tools for the clinicians to diagnose better, early, and with ease. These are the 3 main important things we have to also consider. That it has to be early diagnosis, which is the key, not that the diagnosis, what you are going to do in the first, we are scanning a patient and we are doing the diagnosis in second and third trimester. That kind of feature is of no use, because the best thing is that when you're diagnosing, it should be early, so that the patient gets benefit out of that. Yes, the features what we are introducing should be much user friendly, as is narrated in the initial phase also, that any user should be adapting it better way. So coming back though to the legacy what we are having, we have invented so many things like 3D stick was invented or launched in 2002, and electronic 3D 4D probe today, which is itself a revolutionized innovation what we have brought into. Now, one more important thing, what's our passion and focus? So more and more we talk about the clinical excellence, right? That's what is incorporated and that is what is focused. We talk about productivity and standardization. So SS is one thing very important. Today, we may talk about AI, but what is that AI? What price we are launching that AI tool? So it's not that we are launching that tool in a very higher end product and no one is really affording to buy that particular product. It has to be a different level, so that many more people do have access to that technology. Now, we said very clearly that India is a remote country where 70% of the population or 70% of the area is covered in the rural belt. But definitely those doctors should be also having an affordable solution to invest in that technology. That is something what we talk about, and that is why we talk about the different solutions at different levels. Yes, more focused towards the patient and the user expertise. This will be only possible, as you said, how the physicians should use this technology. So what we are talking more is the digital AI. Education is something very important subject here. So lots of times we invent something, but we don't talk about the education. How are we translating that knowledge to the person who is going to use it? So GE has always been working with lots of experts, ultrasoundologists, who are really helping us doing training sessions at every weekend. Okay, not only we can, even in the big conferences, you might have seen many of the doctors who are associated with the G are working towards the education, so that what technology we are talking in, that has to translate in the clinical outcomes when a clinician scans and uses that. Now, starting from the very early stages where the auto optimization was taken care of, the color sensitivity was really something very unique at that time in the initial phase of the technology came. But starting from that phase to a phase where more and more features are coming, more and more solutions are coming, which are automatically optimizing the best of the 2D image quality. Today, many of the ultrasoundologists who are working on the machine have to set multiple parameters to get the best out of that particular image. It's not that only measurement is important. The first criteria is that what the image you are looking at, that should be the best image to diagnose. That's something very, very important. So here automatically the machine is optimizing best of the images. With that comes the measurement. Like unless and until you don't have a correct image, how are you going to take the measurement? And if you are taking a wrong image and then doing a measurement, that measurement is always wrong. So what we talk here is for the sonobiometry, we do have different sections where the measurement is being taken care of, and there is definitely a reduction in time. You do have faster processing in that FHR. I will not talk about those slides which Dr. Ashok Khurana has already spoken about. So here automatically FHR is being taken care of, and with a single touch the cursor has been kept on the pulse wave and the M mode, where automatically the machine is sensing and taking the FHR. So these are all the AI tools which are really helping. Again, SonoAVC follicle already spoken about, but here we do have advancements also. We now have the SonoAVC antral reserve count as well. So further it can be also in the journal volume calculations. Further to that, we do have the analytics data where we can clearly see how many follicles were scanned on the first day of stimulation, and goes on and on as the we see in the fetal growth. So clearly you can see here, is the pointer visible? No. Okay, so you can clearly see the graph is clearly seen where we can see the right ovary development or the follicles over there, the left ovary development of the follicles, and the number of days as it goes. And it's followed with the correct measurements also seen on the right side of the screen. Not only that, the NT is a very, very important measurement as far as the Down syndrome goes in, right? You need to really have the best view. Unless and until you are not getting the best view, any measurement, any tool is not really working out. And we are also trying to give you the guidance. And if you can see that particular image, there is a notification that the frame is not correct, the zoom is not proper. So machine will help you in guiding to guess the best view, right? End of the day, it's a doctor who is to diagnose, right? So we are getting you the best views. We are getting you the support function here. We spoke about stick earlier times, and I can also say that the fetal heart is the challenge, just scan to be done, because the fetus is itself very, very small. Then you do have fetal heart which is having such a faster heartbeat, right? And to capture that particular heartbeat, it needs a technology which can really acquire that volume, right? Today lots of experts who are there can really do it easily, but there are lots of doctors who are really not doing fetal echo today, whether it is in India or globally. What is really challenging is because there is a limitation on the frames what you can see. But today with stick, you can go frame by frame. You can see every analysis.
Naresh,
And
sorry to interrupt. Wind up.
yeah, I'll just finish some of the slides. So, and now with two steps, we are getting that sonodendral automatically 3D. Now, one more important aspect is that 3D, how fast the 3D can be acquired. With just a trace, you can see the coronal section of the uterus in front of the customer, where they can be diagnosed, clearly seen in the gynecological part. Not only that, you can really further analyze how easy it is to diagnose. Sorry, I'm just running the video also. Now you can clearly see the coronal section of the uterus. Similarly, Sono CNS, which Dr. Ashok Khurana sir already talked about. I'll skip to one of the main important aspect is the Sono list. Now here, what we are talking about is the 20 important sections in the second trimester scan. So here what we are doing is machine is really analyzing all those views. Now it's very, very important. The moment you get the views, you have to really check whether that view is properly taken or not. Now today we do have lots of parameters into that, which are really helping clinicians whether those important parameters are met or not. Now, if you don't have a very clearly identification of those parameters, it's very tricky to tell whether it is normal or abnormal, but the parameters are there. So it really gives the confidence to the clinicians to really talk about that and give the diagnosis on that. So this was all about the OBGYN. We do have lots of in radiology where Doppler is optimally done, tracing is optimally done. A mini section of the sonobiometry is also there. I don't want to go into that, but further, there are lots of AI tools which have been incorporated in cardiology segment as well. Now, many a times when there's a cardiac arrest or there are cardiac abnormalities in adult, so what we do here is we are just taking a particular frame of section. Ultimately, all the peaks are being counted and the best of the measurements are being given. So you can clearly see when we are talking about conventional and we are comparing with the AI, conventional is always really having a intra-observer variability where the traces are not being taken properly. But once you go in automation, all the traces will be done in the fraction of seconds and all the measurements will be given in front of you. So that what we say is a golden hour. So in that particular time, you save a life of a patient is itself a big achievement. So that's what we talk in the cardiology. Similarly, all those steps are reduced to just 2 steps, freeze it and get the measurement. Unless and until you don't freeze, you may not get a proper section aligned to particular that. You may say that we need not have a freezing, we do not have this, but end of the day, you need to have a proper frame, proper section to get the diagnosis done. In an NT scan, if you say that, okay, we are taking just a volume like that, you don't know whether the particular section is being processed, which is really accurate and which is approved, then it start giving the accurate measurement to you. All right. Similarly, I'll just talk about few slides before I wind
We'll
up.
have to wind up.
Yeah, last one. So similarly, we are talking about the LVO over here. So these are some of the things which are really helping the clinicians today to diagnose and get to the level of the final diagnosis. Thank you. Thanks a lot. And if there are certain discussions you need to do, I think we can do one-on-one, but there are lots of questions also people may ask.
Thanks so much. And over to my co-chair for introducing the next speaker.
The next speaker is Dr. Celine Firtion. I think she's online. Can we bring her up on screen?
Hello, can you hear me?
Yeah, thanks Celine for joining us. Celine is a consultant for Philips Innovation Campus, Bangalore. She has 12 years of experience in developing healthcare solutions related to women's health, mother and child care, along with cross-functional team of interdisciplinary teams. Most striking is she has worked as an obstetrician and gynecologist both in France as well as in India. So she brings in herself as an interdisciplinary person, and we would love to hear from her. Over to you, Celine.
Thank you. Thanks for having me. Yes, indeed. So I think I'm going, you're not going to see any presentation. I'm going to bring my clinician point of view. And I'll start with the political point brought by Ashok Khurana. So what is democratizing? I like the democracy. So what does it mean in our context, right? So bringing an AI algorithm that is fair to the customer. So in our context, who are the customers? Because we have more than one customer, right? We are talking, if I look at all the presentation, we talk mostly about doctors, but at the end, it's also the patient that we are trying to reach. So if we want to democratize AI models, we have to make them accessible to any kind of healthcare workers, doctor, midwife, maybe ASHA, or maybe the patient. And in any kind of a scenario, including in the underserved areas. So this is how I understand the question. Now going back to my experience as a clinician working for Philips, I have faced lots of challenges in developing AI, but we've done also great work. So I think I would like to talk about the challenges first, the things that we are not usually brought up if we just think marketing. So the challenges we face are the same whether we work in a corporate research setting or a university setting or government setting. At the end, the challenges related to the cost are the data, right? Getting the data, getting it annotated by the expert, getting fair data, which means you need the data from all kinds of devices, all kinds of probes, and coming from different and multiple centers. So as discussed yesterday, it's one of the major roadblocks to really bring that, to the underserved areas. And if we think pathologies, then, then it's even worse. Like in my area, there are like thousands of congenital diseases. So, how do we get data that represent all that? I think that's one of the first challenge. The second challenge that is quite specific to corporate is regulatory. It's difficult to get approval if for AI algorithm. The road is not completely straightforward because it's a new technique. But there are more and more things coming up. FDA has some guidelines coming up, and what we have to think when we develop now algorithm, we have to think from the very beginning how we're going to go, to get approval, because they're going to look in your data. They're going to look if it has bias. They're going to look if you went across multi-center. They're also going to look how you annotated. What was your annotated processes? What was the CV of the annotators? So that's one aspect. And then, it goes up to the validation study. And for a corporate entity, on top of that I'm talking about FDA, but you have to do FDA, CE, the China one, the Indian one. So it's multiple places that you have to go into to get your tools approved. And then also, of course, there is the fear of liability, right? That decreases the risk taking, I think, in terms of what is done. Another aspect that we have to look, it's the market readiness. In the previous session, at the end, we had a pathologist saying, I don't want AI to be teaching the medical school, right? So the market is ready in terms of awareness. I think now almost everybody knows or has heard about AI, but the trust is not completely there. And I think the main challenge is the implementation of the AI and how to explain for doctors to trust. There are examples given yesterday, right? And today. You have a heat map that is very visible, that is easy to understand, I think, for most doctors. Here, okay, it has recognized that. So I know that it went wrong or, it was right. But it might be more difficult when you talk about something like softmax score that I think Professor Alison Noble showed yesterday in our presentation. How do you interpret and play with thresholds? When is it that, this plan is good or this plan is not good, right? They are also in terms of variability. It's a big problem, especially in ultrasound. So all this area probably has to be, something where we need to work together with the clinicians. And I think that is something we do already from beginning to end. We have a team of clinicians who work on developing algorithms. And I think the other thing is we have to bring the things in the market, and clinicians have to use this tool. As they use their tool, they understand better how to use them, right? I'll give a very simple example, which is not related to healthcare, but to automation. And I usually use it because I think it's understandable by almost everyone. It's the car industry and the automatic car, right? So I don't know if in India we have a few cars that have come up, so you might not have the chance to do it, but I think you can understand. So if it's easy to bring and drive an automatic car on a highway, right? Straight lines, a few vehicles, hopefully no cows or trucks coming the other way. But once you go out and you go on a country road or a curvy mountain road, that tool might not work anymore, right? You might be able to just use the cruise control, the speed control, or maybe just the lane control, but not the full automation. So I think it's the same thing with the AI. In some circumstances, it's going to work. So we need to try to understand practically when it works. I have a good image quality, the fetus has the spine in the back, I can see well, whatever I want, the heart or the stomach. So there I can use the tool. but it's poor image quality. Maybe I need to play with threshold, lower it, or maybe I just need to give up and do it manually. So all this kind of hands-on practice has to happen, and as people get trained and understand better when they can use and when they cannot use these tools. So I think those are the kind of challenges we face. And there are solutions also in terms of for the industry to monetize that. So one is the scalability, right? So if we want AI to reach faraway places, we cannot sell our high-end ultrasound, right? I mean, it's bulky, it's heavy, it's too expensive. So all manufacturers have a different range, right? So you bring lower, cheaper, and simpler devices, and you just need to sell more to make them at the same profit. But if you have those, you can reach far. So that's one simple way to bring things to the market. Whether it's an AI tool or ultrasound machine, at the end, it's about the same. Another way is to offer a cloud solution. I think this is something that is developing a lot. Software as a service. You bring the intelligence on the cloud. Exactly like the tool, the lung maturity software that Dr. Ashok Khurana showed this morning, right? It's on the cloud, but you're still able to do it. And then, you can have a pay-per-view, or you can have different economic models, but it makes it accessible across the world. There are also other approach. So we have seen the 3D tool for the autofollicle. What we have worked on and have developed in Philips is a 2D tool, because in terms of infertility and assessment of follicular count, what we have noticed is mostly lower end machines that are used, and often not, the 3D probe is not used because it's more expensive, because it breaks faster, so for different reasons. So instead of putting a AI algorithm on a 3D solution, we just said, okay, let's try it on 2D. Might be a little more challenging. Accuracy could be around or a little lower. It doesn't matter. At least we can bring it. It's going to be used. And what's interesting in this solution we brought is that after putting it on 2D on a lower ultrasound, the higher ultrasound business asked, can we also put it there? So kind of a reverse innovation this way. I think another point I'd like to bring related to the lab in Bangalore is that we've been now for so many years really concentrating also on low resources setting. And another example that I can bring to is the MOM software, which is mobile obstetric monitoring, and which helps the high-risk pregnancy referral. It's a bit similar to the Smart Health project that was presented yesterday. On top of that, what we are trying to add is also our devices, and for instance, the handheld probe called Lumify. I think there was a question earlier on Lumify. This tool for now is not specifically AI driven, but I think that brings an important point that many issues that are we face to access remote areas and less skilled healthcare workers are not specific to AI. I think, but one point that is really specific, I think, is that we need more complex algorithm for task shifting. So if we want lower skill users, and on the other side, that means that we need a higher level of regulatory approval, right? So if I take again the example of the car, that's a level 5 car, right? I want maximum automation there, which means maximum, challenges in terms of getting regulatory approval.
Celine, we are running out of time. We'll wind up.
Are we on time?
Yeah.
Yeah, I can conclude. So I think there are multiple approaches that are developed to address multiple level of challenges, and there is no single magical solution. And we need multiple players. I think corporate has a big role to play, but we also need push and collaboration from clinician, from government, educational, regulatory, and tech organization. And I think another push that is going to help, and we don't talk much about it, but I think it's important, it's the patient, it's the consumer push. In obstetric, it's always been quite important. I'm thinking of the labor room and patients saying, no, we don't want to go in your labor room, let us go home, or we don't want all these machines, let us walk around. So I think in the AI, these kind of things will also show up. Maybe one last point. I think it will be interesting in terms, we were talking about, I was talking about collaboration, and to have something related to a data hub. If patients can understand how important it is to share their data, it makes a difference. And I'll conclude with just one point related to that. 10 years ago, I visited a Chinese hospital, and in each hospital, they had this huge, computer room where and data entry place. So that means for 10 years, they've been collecting data and entering, and that has helped them a lot, I think. And that's why one of the new article that Dr. Ashok Khurana mentioned in the morning related to detecting lesions in obstetrics came out. They have so much data that they can leverage. It makes a big difference. That's all, I think, for myself from now.
Thanks, Celine. I hope you will be around to take questions if there are any.
Yes, sure, I'll stay.
Next speaker is Dr. Vasanth Venugopal. Vasanth is again an interdisciplinary person. So he is a radiologist and also now into much of AI and data science. He is the chief medical officer at Kaul AI. He's also consultant radiologist with Mahendra Imaging. Over 10 years of experience as a radiologist in several hospitals, including Maulana Azad Medical College. We would love to hear from you.
Thank you. Thank you, Ram. Thank you, everyone, for this opportunity. So 3 years back, I would have been speaking in the previous session as a radiologist, right? Now I'm interestingly speaking in the industry session, right? Being a practicing radiologist. I think that's probably a wake-up call for all the industry people here. We, the clinicians, need to get out and build something to help ourselves, right? That's what's happening now. And democratization is actually the apt talk for this session because it brings and also the right that it's a concluding session for such an awesome conference. And I'm the last speaker. I get the chance to compile together all the conversations and give the gist of what's happening and where we are going. I'll just take 2 minutes. And one of the things I learned moving from academics to clinician is don't use PowerPoint slides. Just use a demo video at the end of your talk. You are done with it. And use a couple of stories and your message is driven home. So that's what I'm exactly going to do. 5 minutes, 2 stories and a demo video, I'm done. So the first story is, right, 4 years back. So I was very much practicing only radiology. I was reading all the scans. And then this wave of AI companies started reaching out to us, right? I was at Mahendra Imaging and they wanted us to test these solutions, start using them in our practice. And as pointed out very well in the previous session by clinicians, so we in fact have many radiologists, in fact, have 3 major issues in using AI solutions. The first one, most important, is access, right? We saw that 2 amazing vendors presenting amazing solutions, very much similar, right? How do I choose? How do I get access to both the vendors without buying those equipments? And how do I test that before investing 20 lakhs or 30 lakhs or 60 lakhs, whatever it may be, in buying those solutions? How do I do that, right? That access is not easy. And believe me, this conference probably would have made you believe that radiology is just ultrasound. That's because Dr. Ashok Khurana is leading the conference. Everybody is talking about ultrasound. So radiology has, CT scans, X-rays, and many other modalities which can operate not on edge, on cloud, right? In ultrasound, the solutions need to be on the edge. By edge, I'm meaning that they should be on the system so that they immediately give the output to the sonologist who is doing the scans, at least in India, because that's how the workflow is in India. Radiologists do the scan, they need to see what's happening before completing the scan and sending the patient off. But in many other Western countries, even AI solutions can operate on cloud. So we'll come to that later. The number one problem is access. How do I get access to these different solutions which are incurring any cost, to compare them and trust them, right? That brings us to the second question, the trust. Second problem, the trust. Again, Deva pointed it out, Dr. Jain pointed it out. So how do I trust these solutions? To trust these solutions, I need to test them on my data, right? On the data from my practice. I'm sure that, all these validation studies, all these research studies are perfect. Even Dr. Anurag Agarwal pointed out, thousands of validation studies are published, and none of them are usable in clinic because they can't be tested on your data. So I need to test these solutions on my data at scale, right? Not on 10 cases, I need to test them on 500 cases. I need to include in that test set what data scientists will call as edge cases, toxic cases, and whatever corner cases possible. Because for me, my work operates at the N of 1. I can't go wrong even with a single patient. I have to be correct all the 100% of the times, right? I can't be just 99% accurate and let go one patient with something missed. So I need to test it at scale, so that there was no tool, at least before we built up Carpal, to test different solutions at scale on my test data. The third important problem, so it's very important, is integration, right? All the hospitals, health clinics have a very small IT team, right? I can go to them and tell them, right, integrate 10 solutions, 10 different players, talk to them, integrate them, bring to my practice, I want to use them. So that's not going to happen, right? Because all of these solutions will have different ways of operating. Some of them use what you call as Docker, some of them use REST APIs, some of them receive DICOM pushes. Your IT team, the hospital IT team, is going to get exhausted. So all these three issues, the access, trust, and integration issues, that's what we are trying to solve at Carpal, and that's we are trying to do, democratize AI. And two stories again. One story is done, two more stories. The second story is, again, 4 years back when I was practicing at Mahajan Imaging, I used to do evening clinics at Mahajan Imaging, morning at a different hospital. The evening clinics, most of my scans used to be either MR spine for degenerative disease, MR brain study for stroke, or X-rays for degenerative, X-rays for fractures, or lower limb X-rays for measuring the limb angles. That's the patient mix, or maybe NCCT's PNS. These are different studies done for different use cases. Today, there are regulatory approved mature solutions that are available that can automate to a certain extent certain features of all these studies. Using Carpal at Mahajan Imaging at the clinic where I practiced, now we run all these studies through different AI solutions and get back the results to the practicing radiologist. Now, in fact, I'm not there. Someone else has taken my place there. The AI has replaced me literally there. So they are happy using that solution. So that's what Carpal has been able to do. The third story is that, again, when I was doing clinical practice at Mahajan Imaging, one fine day, family came to our scanning center, and there was a small kid, 4 years old child. They did MRI brain because of poor attention deficit in the classes. And we ended up seeing, unfortunately, a brain tumor in the posterior fossa. Right. We knew that in the first scan itself. We wanted to do the scan faster. So it's not possible, right? We need to spend 20 minutes, and we didn't want to do contrast if possible, because it's an invasive thing, and that's a child. And number three, we want to provide as much as information possible based on whatever study is available, and want to give them right away immediately. Today again, so there are solutions which can make happen the scans faster, help you to use the contrast at a smaller dose, and provide multiple information which a radiologist can immediately get access to, AI solutions. And all these solutions can run on a single study. These are again from different companies, different vendors all over the world. Again, Carpal has made it possible to run multiple solutions, close to 5-6 solutions on a single study and give back all the results to the radiologist even before the patient comes out of the scanner. So that's what is possible. That's what democratization is. I will stop here. I'll just ask them to run a demo video of how Carpal looks like, how the platform looks like. It's just 2 to 3 minutes. Then we'll open up the question and answer session. No, panel discussion. The next video, please. Yeah. So this is the platform login. So this is the orchestration layer of the platform. This is what you used to set up these different solutions in your hospital or in your clinic. And on Carpal, there are so many solutions now integrated. As I said, close to 50 solutions are available on Carpal. Different, commercial solutions, some open source solutions, different vendors that can easily, flow through your data at your clinic. So this video is showing the range of solutions that are possible. In fact, if you observe there are solutions doing the same thing, multiple solutions, just text reclassification. The idea here is to enable you to give you the power to choose the solution, right? Some of these solutions might work best for your practice, some of them may not work, but you have the choice. You can choose it. You don't need to invest in them before testing them and trying out in their practice, right? As they call, try it before you buy it. So those are the range of solutions. And the solutions which are doing fracture detection, solutions doing chest nodule detection. This is how bring in data from your packs or your modality onto the system. You can just enable a DICOM receiver. So some of the tech people might understand this. So you can enable a DICOM receive server on the platform, and then you can connect it to the packs. Now all your data can easily flow onto this. This is a single layer of integration, and then they can be diverted to different AI solutions depending upon what you want to use for different AI, depending upon using this workflow orchestration clinic. In this case, what you're trying to do is we're trying to test 3 different AI solutions on the same data set to see, which is the best one out of it, right? It could be, say, just for an example, it's GE, Philips versus Sonoscape. You can easily do that on the platform. I'm sorry to say this. So that's possible on the platform, using the platform. Again, all solutions are very mature. The only difference between them is, the way they are trained. They may work on a particular data set better than on a particular, different data set. You might have a OPD clinic, you might have an inpatient clinic. Some of these algorithms can work better on OPD settings as compared to the inpatient settings. So that's how you orchestrate the workflow. And then now you can, the radiologist who is going to read the scans can see the results on the platform. Now these solutions have started running in real time. They will also know the flow of data through the platform or different AI solutions, and they will get to see the 3 results of 3 different solutions. And then you can see at a single place. So these are what we call as the inferencing outputs from different AI solutions. And there is a custom inbuilt viewer on the platform. So these are ROIs from these AI solutions, which you can see on the platform. What you see is the different findings as detected by the AI solution, nodules, pneumothorax, proliferation, and so on. And one of the important things which we can do through Carpal is scale, lab-built AI solutions, right? If you are a researcher who is building AI solution, if you want get access to hospitals, we're happy to host your solution. You just need to maybe Dockerize the solution, or maybe we can help you with that. If you just have the weights, we can integrate with the platform and deploy it wherever we want to and get you real world insights. And if it's possible, if your solution is of interest for a clinic, it can even go to the commercial pathway also. I think I'll stop here. Thank you so much for the opportunity. I'll go there and take it.
Thanks, Vasanth. So we are running short of time actually before we go for break for lunch. So I'll take the privilege of being a coordinator and ask the first question. The larger thing, if we are going to divide the tools, AI tools in these ultrasound machines into 2 major crude boxes of assistive and automating tools and predicting clinical outcomes tools. What we have seen remarkably is all the assistive and automating tools are all developed faster in a R&D lab, which is associated with the company. They are much faster than academic institutions. It seems to be like that. Of course, there are many inputs from academic institutions also in their softwares. But when it comes to tools that are able to predict clinical outcomes, say, for example, if someone is going to use ultrasound and predict a preterm birth or a stillbirth, clinical outcomes, that's where beyond the interaction with industry and the practicing clinician, there has to be a scientific team which has to come in, because then a robust study has to be designed and it has to be implemented, data has to be collected in a robust manner. And then those inferences have to be validated before such a predictive, clinical outcome predictive tool can be incorporated into an ultrasound machine. So the question to the industry partners here is, how are you engaging? Are you interested in those kind of tools to be put into your machines? If you are interested, how are you visioning a process where you can involve robust research groups right at the beginning to be able to implement this? Any of you can take, including Celine.
See, as one of the speaker mentioned during the session, is the regulatory requirement in this kind of second case, which you mentioned, is much tougher. So usually the industry tries to avoid going into really classification of the or identification of a benign or malignant, just for example. But to a limited extent, as probably I showed in my presentation, is like a classification of a breast lesion or thyroid lesion as per the TI-RADS or the BI-RADS that we have already incorporated into. But obviously, I think the reason why industry don't go into the second segment, which you mentioned, is because of the regulatory. It becomes too just taking measurements or naming it. That can be managed or regulatory proved. But classification or really detection of malignant benign, that is really challenging for industry to even venture in.
So I just a little differently. See, there are two aspects in the Ram, you said correctly. There are two aspects. One is the automation, how it's bringing the measurements. Another is the clinical part. So clinical part definitely is little more complex. Like there are lots of rules which we have to follow as far as the industry is concerned, or any clinician has to follow, because end of the day, it's a diagnosis which anyone has to do. Now, I may say also there are lots of experts who are working with the industry as well. It's not that industry is developing everything of its own, right? As I said in my presentation also, Dr. Iris is part of lots of innovation in AI, and lots of times we have been consulting Dr. Ashok, Khurana sir, and many other experts who are really giving the guidance to an industry today. Now, lots of automation, lot AI which is coming. It's not coming just because industry is developing. It's combination of a teamwork together, right? Different people are coming forward. Maybe today you may not see lots of names, but I am sure that in future we may hire lots of people coming up front on the stage, or the names will be out there, which we'll be recognizing at that time. Thanks.
Rightly said, right? The regulatory barrier is very important, especially to move from just a assistive tool to a predictive tool. That has to be taken care of, and industry is very careful about it, because they're building for the world, right? Even though in India, the regulatory barrier is still kind of borne by the radiologists, they're building for the world. They have to be compliant with regulations all over the world. That's where the challenge is. But again, as I gave a call during my talk, for any research group trying to get a feel of how good their solution is it worth pursuing a commercial pathway for that solution, we are happy to help with them at Carpal.
Celine, do you have a point to add? Can you,
Yes.
can the IT team bring Celine also on the screen, please?
Sure. Yeah, can you hear me? Yeah. Can you hear me?
Yeah.
All right. Okay. Yeah. Yeah, I think rightly so about regulatory and also implementing on the cart or, on the device, because when you develop something in research and you want to put it on the machine, it's not just you put it that way. You have to adapt. There are all kind of, technical issues that make it a little difficult, and you have to compare whatever your accuracy was, when you develop it versus how it is once it's on the card or on the device. I think another point maybe that can be helpful for people who, don't work in corporate settings is also to look into trying to first prove how it works by using, plugin. So you just capture the image from outside, you run your algo and go to different clinical sites and validate And if you validate it and you prove, it works very well, it can be used either further like that, off the cart, or, you might raise the interest of one of the big corporate companies. I can give you an example, for instance, with Tomtech, who is doing the strain analysis for the heart. So first, they came as an external vendor, and they can be put in any cart, and then we're using any cart, and now we are trying to integrate it directly into the cart to make it easier. So just think also sometimes, how to go beyond the roadblock. Yeah.
Thank you. And moving on to that very important consideration of cost and scalability. Naresh, what is your company doing about that?
Thanks for the important question today, because in India, we always talk cost first, but I just want to take it a little bit differently. See, today, differently, there are lots of innovations happening globally, right? I think any organization needs to develop it at the different levels, right? We really need to develop a solution which can be given in a different kind of a packets or a packages, right? Now, first is this specialization, which we have to consider, and we need to have a kind of a tailor-made solution, which gives a best of the value or a ROI, right? Today, if you're investing in a technology which is meant for the masses, let's have a less of price tag towards that and bring it to a level which will be affordable for many other people all across, right? If you're bringing some technology at the top end level, yes, there are lots of technology which will be on the very high platform, but same time, I think industry has to develop different solutions at different price point. And that's the reason if you see GE is always having the wide variety of solutions for every clinicians today. There are different series and different price points with different packages, so that any clinician needs a specialized solution at that price point. So that's available for them. It's just like a tailor-made solution for all of them. What you can afford, what you want, that's all there. It's not that you have to compromise with certain features which you are not going to use, but anyhow, that's made in, that's put in the cart and you have to pay for that. So we are having different solutions for different levels for all special.
But I noticed also that some of your technology, as soon as it gets a few months old, starts behaving like cell phones, and you transfer high-end machine technology to low-end technology, and that machine is actually cheaper. So you are automatically doing that.
That's what migration of the technology is happening in GE.
Yes.
Sometimes down, and we will take the machine up to that level, can take that automation.
Right.
Yeah, thanks. So see, there are a couple of things. One is this kind of technology has to start with the top end machine, which every one of us will agree, because the investment which a company does in R&D, usually it is put first in the top end machine. But it depends on the philosophy of the company also. See, like if the headquarter, for example, just the headquarter of that company appreciates the need of real AI, which will be useful in a country like India, then probably the same product might be available first. That feature might come down to an entry level product. I firmly believe that AI is needed mainly is the entry level. Experts don't need AI. Only in India kind of country, in districts, smaller towns. So that's the philosophy of our company is we are offering number one, we put all the application as I showed you on our top end machine. Then we realize like a country like India, which feature, for example, from our experience, which I said, the auto measurements of all the fetal parameters, that's 90% of the doctors, even in an entry level, use that feature. So what we are doing, we are that particular section of AI, we are putting into our entry level machine, and we are offering the AI, real working AI at our entry level so that it reaches the masses. So country dependence, the need that really comes from the top, and company realizes that we should really help the end patient. So I think we are able to do it even now.
Hello. We are doing things differently. What we are trying to do as a platform, we are aggregating the hospital sites globally, not only in India. So that kind of gives us a power to negotiate with these global AI companies to procure inferences at bulk and cross subsidize. When I say that, the same solution which is available, say at $2 for a deployment site in US, we are able to deploy that at an Indian site for 10 cents.
Yes, but isn't that different for CT/MR X-ray compared to ultrasound? I noticed that what you're offering is for the other modalities.
Correct. I'm talking about modalities where there is a cloud inferencing happening.
Yes.
The solution, the data goes to the cloud or maybe goes to the Docker, gets inference and comes back. And the way these models operate is, they charge per inferencing, right? If there is a solution which can automatically analyze the spine MR and then give out measurements and then give certain automated report, if they are charging say $2 in US, we're able to bring that at 20 cents to Indian side, purely because of our ability to cross subsidize.
So that's for the predictive aspect
correct.
of AI.
Yeah.
And what's
Predictive and automated quantifications.
Yes. Celine, what is your take on this?
I think the challenge is when you make an AI ready for a certain type of machine, so high-end, and you want to bring it down to your lower. You also face issues, right? So if I have a let's say a big machine from Philips, and then I want to put it on Lumify or Clearview, the GPU power is not the same. The image quality is not the same. So my algorithm might not work. I need to refine it. So it's extra work, extra time to make it work as well on lower ends. But again, you're right. I mean, AI is probably most useful at entry level. So as I gave the example earlier, right? We went 2D with a lower machine, and then we brought it in a higher machine. So it's what we can do it the other way also as well.
Thank you. And that brings us to the last point that we're going to ask from the panel, and then we'll take 2-3 minutes extra because they ate into our coffee time. We'll eat into their lunchtime. What do you think? Education. How are you doing that? Physician education, user education.
Thanks. Something very, very important. As in my presentation, as I also said, that education is one of the focus area what G is talking about. We have brought in two different thoughts into that. One is we are launching lots of new tools in different levels of our product series. And whenever we are launching any particular tool, we do have education videos inside these machines now. Like, for example, if you do have a machine which you have bought, right? All those tools which are available in that machine, you do have a video inside that. So that one is that aspect that whenever a user wants to learn something about that particular tool, so everything is available in the machine. That's point number one. Point number two, we do have a support function of application team in all the regions across India and globally. And third thing, very, very important is we do lots of education programs with definitely the experts, all right, continuously, so that whatever technology we are inventing or having an innovation about, it really is understood by the masses so that they can just use it. See, unless and until people are not going to use the AI is of no use, right? Many of the doctors who don't know how to use it, you may have a technology in the product, but then how are they going to benefit the customer? So best thing is the education in all the different aspects are very, very important. And a relevant thing is that you have to bring education to the last end of the person who's the clinician over there. Thanks for this question.
But can you teach me from far away, like we did during the pandemic?
So again, I just want to talk about this. We do have latest gadgets which we have really introduced is the digital expert. What happens is we are taking the console remotely and we are training the user. Like, for example, someone sitting in the northern pole of India and someone who is in the southern pole of India. So you can take the control of the machine, and the application person sitting remotely can really have a full control. They can have a discussion. The application person can clearly see what scan is being done, what are the parameters are being set on, how they can use the feature, how they can manipulate, how they can change the direction. They are all available today as a solution part in this particular education format.
Mahendra, you probably have the same problem that we don't have as many applications people as we need. How do you handle it?
Sir, I take it a little differently. I think exactly what just discussed right now, the conventional kind of training keeps on happening. There are only few companies in ultrasound, if I talk. So most of them use the same way of training. But I think a great example which Dr. Khurana reminded is during the COVID time, there were so many webinars happening every day because it was a kind of lockdown. And like Dr. Khurana, even he might not be using a particular company's machine, but he supported that company to do lectures because his intention was to educate the community of doctors in across the country, and there was 1,000 doctors attending his webinar. So that kind of training is continuous, but I think AI training is totally different. This AI presently in situation is only in the top end, probably addressing select doctors. So AI is, I think we don't require training for AI. Then what is the use of AI? So AI training has to be on a specific doctor. So when the machine gets installed as his center, we need to have clinical specialists spending 1 or 2 days so that he gets his own data, as you mentioned, on his own patient. We don't require a proper classroom kind of training for AI. AI training is required like shear wave elastography or very complex scans or technology. AI is simplification, which he has to do within his patient. So I think that's our point.
Correct. I think he's talking about access. You give them the access, they will learn. Right. And being a radiologist, it helps me to talk their language. It's easy to kind of educate to them, and the education also two-way, right? So the radiologists also interact with the developers or the vendors and give their feedback, and they do the modifications. So if you enable access, if you give them the right tools, they will learn.
Great. Celine, would you agree there that
Yeah.
access is all that is required?
Yes and no. I think it's a bit of training in the beginning helps, but we face challenge. So there are different ways to do it, right? So for instance, Philips has something called Collaboration Live, which is a telehealth solution. So you can do remotely the teaching. The other way is, I think, what was mentioned earlier. It's about having a clinical specialist the first few days with the doctor at the place, with the doctor or healthcare worker, spending time on patients and trying to for them to try to understand how it works. And I think at a corporate level, the issue is to train the sales personnel, right, and the clinical specialists, right. So they have to also learn new tools, because it's not just the healthcare workers. It's also within the companies for the sales force. It's also a new kind of tool. Yes.
Thanks. So to get, to avoid getting lynched by the organizing team, we'll take one question online and followed by one question in person. Online question, please.
Hi, this is Anjali. I'm a radiologist. I do teleradiology, emergency radiology, and I've really enjoyed the sessions. Very stimulating. I just wanted to add one thing and also ask the experts 2 questions. I think awareness is the first step to acceptance. So we've made the physicians aware, and hopefully, they would be willing to accept since they're aware of the AI tools. But to get to scalability, the tools have to be user-friendly and they don't have to come in my way. And to that end, I wanted to ask Vasanth one question. Vasanth, I love your Kaul platform. I've used it and it's really great. And the concept is beautiful because you're offering the physicians, a one-stop shop to be able to choose the tool that they like. And I think for bigger practices who already have PACS, they can probably get these tools working in the background. And perhaps the tools can be automatically activated based on the study type and the clinical indication, which we do at our end, because I do emergency radiology. So once I get a CT head, so the AI hemorrhage, AI hydrocephalus, midline shift, all those tools get activated. But the question is, when it comes to smaller practices that don't have PACS, how do we make it user-friendly for those radiologists?
Sure. Thank you, Anjali ma'am. Very nice question. And thanks for giving me the opportunity to explain this too. The Carpal platform can be a PAX too. So we don't kind of call that out quite openly because we don't want to compete with the PAX companies. So they can be, it can enable a DICOM service, and then it can be a PAX. That's where you push all your data, and then that gets stored. Coming to how do we orchestrate the different AI solution, we have enabled certain validation rules inside the platform. So if it is a head CT scan, NCCT slices are automatically identified based on the metadata tags, and then it orchestrated to the AI solution which you have subscribed to. It could be a solution by Cure or Avicenna, which does the automated bleed detection. It will get automatically routed, and the results will come back to the modality of the user itself, or they can log in onto the platform and see that. Similarly, chest X-ray based on the metadata tags and other validation rules. All these automated routing facilities are built inside the platform. So even for small practices, they can just hook onto the platform and.
Oh, so that's what I didn't know, that it's also a PAX. So
Yes.
that makes a lot more sense now.
Correct.
Because I was wondering, otherwise it would really slow down the radiologists, to be able to now run their images through this and then come to a conclusion. So that was my fear. Thank you.
Yes, and I'm sure this session is not being recorded. We don't want to compete with PAX companies. Okay, I was just joking.
So of course it's recorded. We like people to know these things.
So
that's a useful point. That's a very useful point.
Yes, thank you, ma'am.
One offline.
Yes.
We promise that.
Great session. Thank you very much for this. This question is mainly for Dr. Vasanth. In many of the hospitals, at least in the settings, we have a lot of legacy systems. It's also applicable to other people as well. So how do you handle these legacy systems and integration? Because I see that as a biggest bottleneck for AI to make any strides there. Because we are talking about going to small places, giving the access, but getting that access is going to be coupled with dealing with legacy systems.
Correct. So that's one of the pain points which we try to address. Even with legacy systems, what is amazing about radiology practice is the DICOM standards has been there for close to 20 years now. So if you pick out an imaging study, there are tags, predefined metadata tags, and there are fields which should have the entries which you need there. Some of the systems may not manually enter those fields. It might stay empty, but from the PACS itself has a structure to it, which has been followed. Even the legacy systems, they may not have the new features to that. So while you are integrating, the thing you are going to do there is you are just going to do a DICOM QR, auto QR, or push a output back to that. That's possible with any of the legacy systems because those are basic rules of a DICOM integration. So we build upon those basic rules and integrate with these DICOM systems. Of course, we may not be able to deliver many more results which we want to the legacy systems, but a simple integration is very much feasible thanks to the DICOM standards.
Yes, and that's true for the predictive algorithms I showed this morning from Barcelona, which are, again, as long as you have a nice DICOM image, it can go across several vendors. You don't have to be vendor specific, and we could have across various platforms within the same company, and all those images will be completely acceptable, and the software will reject what it doesn't think acceptable. But I've used them on point of care machines, and it's worked equally well.
It's a very important point what you said, but we had come up with the one solution, which is a particular kind of a package, Viewpoint 6, right? It's a software which takes images and data set from multiple different vendors as well, not only G. If you are having old machine, the latest platform, even different vendors are also having. So we can capture all the data set images and put it into that particular server so that what kind of analysis you want to do, you can really do that. So a platform has to be at the level which is accepting all other vendors on that. So we do have a solution for that. Thank you.
With this, we'll wind up this session. Thank you for all the panelists for being here and forthcoming with the answers for most of the questions within the limitations of industry and commercial angles. So I'll hand it over to the organizing team.
That was a wonderful discussion. I thank Ram and Dr. Khurana for coordinating the session. Can we have clap? Yeah.